Can we start the class, sir? Can we start the class, sir?
Dr. Diritiman?
Please. Yeah, start.
Are you seeing my slides, sir?
Yes, Dr. Nandakumar, we can.
Now it's visible, yeah.
So today we are going to see the article was published in JAMA 2024, the effectiveness of lumbar cerebrospinal fluid drainage among the patients with aneurysmal subarachnoid hemorrhage is a randomized clinical trial. So now coming to the background. So everyone knows that the aneurysmal subarachnoid hemorrhage, there is increases the mortality and also there is increases the disability. There is a more morbidity is there behind the subarachnoid hemorrhage. Even there is a development in the surgical technique and neurocritical care and the neuro interventions. Still there is a mortality, morbidity is going to be is very high, mainly because due to the development of delayed cerebral ischemia. Initially we thought that pathophysiology began the delayed cerebral vasospasm is only the vasospasm. Now there is only the 50-70% there is a vasospasm chance. The remaining 40 to 50% there will be multiple factorial. It is a neuroinflammation. Because of neuroinflammation there is a blood-brain barrier is disturbed. There is a cause brain edema, and also because of microthrombosis, cortical spreading depolarization, and oxidative stress. Now mainly we are going to see today why there is this study have been undertaken. Main pathology behind there is a delayed cerebral ischemia is blood in the cisterns. That in the mainly blood in the cistern will cause blood and blood degradation product will cause a deterioration effect in the brain. That is a delayed cerebral ischemia chance, and secondary brain injury was more. When the free hemoglobin is there in the system, it causes decrease in nitric oxide production. This nitric oxide production which causes the more vasospasm and decrease in cerebral blood flow, and also activation of platelet activation. It causes microthrombosis, and also there is a neuroexcitatory mechanism which takes place, and also they affects the hypoperfusion due to the there is a cortical spreading depolarization, and also inflammation signals. There is inflammatory signals will be activated. It causes a brain edema and causes secondary injuries were there. So main the background of this is the study have been done because due to the vasospasm is degraded by the blood in the basal cistern. Main there is a removing of the blood from the cistern. If it is going to decrease the delayed cerebral ischemia and vasospasm, that is only background of this study. Coming to the research questions and objectives, the effectiveness of the early lumbar drainage is going to improve the neurological outcome following the aneurysmal subarachnoid hemorrhage. It is a clear relevant questions because most of the subarachnoid hemorrhage they have complications we are going to see. The population intervention they taken will be the early lumbar drain they placed with along with the standard of treatment. Along with standard of treatment. Hello? Along with standard
Please continue.
The echo was coming, sir. The population here they taken was a people of there is a participants involved in the subarachnoid hemorrhage. The intervention was early lumbar drainage placement, and the compared with the standard of care. The outcome they seen is there is a modified Rankin scale. That is an outcome. There is a morbidity outcome. The 6 months durations they have seen. This is a Picard. Mainly this study was influenced from the LUMAS trial. This LUMAS trial, when this early train was published, the LUMAS trial was not published during that time. The study was going on, LUMAS study was not published. They were influenced from the LUMAS trial. That is a single-centered randomized control trial. They taken it was mainly they taken the World Federation of Neurosurgical grades were very 1 to 3 grades only they taken. They are saying there is a delayed cerebral ischemia was significantly there is improvement was there, but early there is a difference in modified Rankin scale was 10 days was there. It was not extrapolated towards the 6 months duration. This study mainly it is a LUMAS study, not the early train study. In the LUMAS study, They train FNSS grades were mainly 1 and 2 grades were there, and more modified Fisher's grades were 2 and 3. The 3 and 4 there is a very less. There is a thick SAH with interventricular extension group are very less. So in the group, they are saying there's a delayed cerebral ischemia was significantly lower in the study group. Even in the first 10 days, there is a modified Rankin scales were modified Rankin scale where the score was 0 to 2. The modified Rankin scale 0 is patient is healthy patient, 6 means patient is a death patient, 0 to 1 means there will be non-dependent on anyone. This modified Rankin scale 0 to 2 was in study group, there was a significant people were there compared to the control group. This statistically also significant. If it comes to the 6 months duration, there's a statistical significance or not there. So same thing we discussed. Now coming to our study, this is a early train trial. That is a pragmatic, it's a more practical oriented study. It is multi-center. It is taken from the multiple places, mainly from the Germany, Switzerland, Canada. They are taken from the 19 centers. It's a parallel group study. This is randomization, 1:1 randomization was done. It's a parallelly, one group was standardized, one group was given a lumbar drain was placed. There is a no crossover was not there. There is a parallel group study. It's an open label randomized clinical trial. There is a one bias in the open label randomized clinical trial. That is a both patient and participant aware of the treatment what is going on. But there is a there is a hello.
Continue.
The treatment was the outcome assessor, because after 6 months, when there is outcome was assessed, mainly the assessed modified Rankin scale, that is an objective parameters. When they are assessing objective parameters, there will not be bias, will not be there. Bias will not be there. If this is from the open label study, because the outcomes assessor was blinded, it minimizes the bias of the overall results. One more bias is the taken from the study duration were from January 2021 to January 2016. The long leave period was there. This was one of the flaws in the study. Coming to mainly to get an ethical approval is obtained from the all countries. Mainly informed there is a consent is obtained from the patient. If the patient is not giving a consent, is the next legal representatives will be given the consent. Only in Germany, when there is an patient is not able to give a consent or informed consent from the legal representative is not available, there is an independent physician can give who is not treating the patient or is not included in the trial, can give an independent physician can give an approval can be given. It was not followed in Switzerland and Canada. In Switzerland, Canada, the next keen person who is responsible can give an consent. This trial was.
Can I stop you here? And,
yes, sir.
I want to talk to the people a little bit more. Can I share my slides?
Yes, sir. Sure.
Okay. Okay. Are my slides visible?
No, sir.
No.
Yeah, now it is visible, sir.
Okay. So, if I speak in a lower volume, is it echoing still?
It's not much, sir. It's okay.
Yeah. Anyway, I can't help it. I've tried everything, but I can continue. So,
It's echoing.
It's echoing too much.
Not too much, sir, but it's echoing. But we can able to hear.
And I don't know what to do. Shall I log out and log in again?
Now it's okay. Better only, sir.
Okay, then I'll continue speaking. Okay, so the study designs, like I wanted to talk a little bit about study designs at the period when you're talking about the study designs in your. Okay, it's getting really messy. I don't think anybody's able to understand anything. Okay, I'll just log out and log in again. I think that's better.
Yeah, try that. It's echoing a lot.
Yeah. How is it audible now? Is it better?
Yes, better.
Okay, chalo.
Yes, sir.
Now
Thank you.
let's get to it. Yeah. Okay. So, how I wanted to conduct this session was that when we are reaching some specific area of the office presentation, I wanted to elaborate on certain topics so that everything stays contextual. Okay. So, having said that, let's since he described his study as an open label randomized control trial, I wanted to tell a little bit about the types of research studies that are and the hierarchy of them. This is something that most of you will be anyway aware of. So I'm go very quickly through this. Okay. So the study that we anyway try to publish is a case report. That's like a single case or a case series in which there's not much of evidence. It's more of telling the other people, okay, I saw something interesting and this may be the cause of this interesting phenomenon. Okay. So it doesn't hold much scientific weight. However, these type of case reports do lead to more and more information gathering, which can eventually lead to some type of study. Okay. Beyond that, for certain types of discoveries, you need animal trials and in vitro studies. They are one separate branch. Okay, they are clinical, so they are a separate branch. After that, coming to the clinical trials. In the clinical trials, you have got cross-sectional studies. So how these studies are defined, like these nomenclature of cross-sectional, case control, cohort, RCT, and meta-analysis, how they are defined is based on the relationship between the exposure and the outcome. Okay. Always, whenever you have any sort of study, what you are eventually trying to see is trying to establish a relationship between a cause and an effect. Okay, so that is the one of the major points of any study. Okay, so how cross-sectional studies are when the exposure and the outcome, or the cause and the effect, are being seen together at one point of time. So you are not following up any patients. At one point of time, you are basically taking a cross-section of the population. You are seeing how many have the cause, how many have the, and then you try to derive some information from it. That obviously comes with a little bit of bias that you do not know the temporal relationship between the cause and the effect. So that is why cross-sectional studies are a little bit flawed. Next, coming to case control and cohort studies. For this, I want to show you this diagram. So in this diagram, you can see that like cross-sectional study, when the exposure and outcome happen at the same time, then it is the cross-sectional design. However, when you go from, like, you are checking in the population now for the outcome, like suppose let's talk about smoking and lung cancer. Okay. So when you are looking for patients with lung cancer and some patients of the normal population, and then you are following up their history to see if they smoked or not. So basically you are going from outcome to exposure, then that design is called a case control design. Okay, that's the nomenclature. Okay. Next, when you are going from exposure to the outcome, meaning that you are taking the patient, people who are smoking or not smoking now, and you are following them up in the future to see if they develop lung cancer or not. This is called a cohort study design. So in this, basically, whenever you go from exposure to outcome, then it becomes a cohort. Whenever you go from outcome to exposure, it becomes a case control. Now, the confusion most people have is when they hear the term of retrospective cohort study design. Okay, because technically we are seeing the patients as exposure and then leading up to outcome, right? So this confusion gets resolved when you see that even in the retrospective cohort study designs, you are looking at the records of the people to identify who had smoked in the past. And then you come back to the future to see, or the present, and see whether they had developed lung cancer or not. So the direction of exposure to outcome remains in a cohort study design, whether it is retrospective, whether it is prospective, whether it is ambispective. Ambispective meaning you are seeing the exposure in the past by the medical records, and you are following them up to present and the future to see whether they develop lung cancer or not. Okay. So, okay. Next, in these though, you are not actively doing anything. You understand? These are just observational studies in which you are just observing. The intervention is happening automatically at the patient level. You are not intervening by yourself. You are doing nothing specific. Okay. However, the main studies. And the next control patient who does not get the intervention. Okay. Yes. Okay. So in the randomized control trial, you have the power to give some people the intervention or the exposure, and some people you do not give. Okay. Now I'm saying you have the power because you are making a decision to give. However, you do not get to decide which patient gets it, which person gets it, or which case gets it. Okay. That is random allocation, in which you are allocating an intervention, but you are not in control of who gets the intervention. Okay. So that is randomized control trial. Now, what is the point of randomization? Now, what happens is that, like in a cohort study design, suppose you checked up on people who had the exposure and or suppose the smoking, and then you followed them up to lung cancer. Okay. However, there can be so many other factors which can influence your connection between the exposure and the outcome. Like suppose the patient was already hypertensive, or the patient has some adrenal tumor, or there can be many other reasons which can actually lead to the outcome of lung cancer. Okay. So, so the expectation when you are doing randomization is that in your control group and your intervention group, you expect that all of these confounding variables get like sort of randomly dispersed equally in both the groups. That is the main point of random allocation or randomization. And because of that, RCTs are at the top tier of these clinical studies. Okay. Now understand that it is just an expectation that the randomization will lead to even distribution of the confounding factors. It is not a guarantee. That you will know after you have collected the data and after you have analyzed the results. After that, if you still see some confounding variables having uneven distribution, then you have to arrange for them statistically. That we'll talk about later on. Okay. Now, beyond that, the only next level is meta-analysis. When you have got a lot of cohort studies, cross-section studies, and RCTs, then you combine all of those studies to get overall more generalizable results about the connection between exposure and outcome. I hope this part is a little bit clear now.
Yes, sir.
Yeah. Okay. So, yeah, I guess you can continue then. I will stop sharing. And Kumar, you can continue.
Are you seeing my screen, sir?
Yes.
So now coming to our study, the trial was conducted in mostly the 24 hours they were treating 24 hours basis. They were treating for subarachnoid hemorrhage. Both neurosurgical, neurointervention, neurocritical was going on, and also at least 30 aneurysm procedures per year was conducted. That group of place was taken. Mainly the intention to treat analysis was tried, and the protocol and analysis plan published prior the procedure. Mainly the trial procedure was taken was
Okay. Nankumar, can you pause for a bit? Again, the echo is happening. I think Nankumar, the level, it is happening at your level. Can you mute yourself? Now is the echo happening? Now is the echo happening?
No, Dr. Kumar, it's good.
Okay, I think it's at Nankumar's level, like some speaker echo is happening because of that. But it's okay. I'll just quickly say what I wanted to say. So here he said that there is a specific type of analysis mentioned in this, which is called intention to treat analysis. Okay. Now, I want to make this clarify this for people. There are broadly 3 types of analysis when it comes to these type of randomized control trials. Okay. Now, what happens is that you have got a group in which you are doing an intervention. You have got another group in which you are not doing the intervention. Okay. So initially, when you allocate the patients, like in this case, one group got the early drain and one group got conventional treatment. Okay. Now, intention to treat analysis assumes that whenever the allocation was happened, then the study continued within that allocation itself. It ignores any crossovers. Okay. Now, suppose one of the patients in the control group started going bad. Okay. The clinician took the ethical decision to put a lumbar drain in that patient. Okay. So because of that, that patient now technically becomes a lumbar drain patient, right? However, when you do an intention to treat analysis, you still keep that patient in the conventional treatment group. You ignore the fact that there was a protocol violation. So basically sticking to the allocation, the initial randomized allocation of the patients, assuming that that is how they continued and then checking the outcome is intention to treat analysis. It is an intention to treat. So you are basically beforehand setting that this patient is this and this patient is this. Okay. Now, next comes the as treated analysis. As treated analysis means that the patient who got allocated, to the conventional, but later on went to the drain group, lumbar drain group, now becomes a part of the lumbar drain group. Okay. And if the allocation of lumbar drain, the patient because of any reason could not get a lumbar drain, then or the lumbar drain stopped working or whatever happened. Okay, so they reverted to conventional treatment. That patient then will get treated as the conventional group. Okay, so basically as treated means that after you start the treatment, if there is any protocol violation and they switch over, crossover to the other group, you analyze them based on that crossover, like where they ended up and got treated, that is the grouping for that patient. Okay, that is as treated. The last is per protocol analysis. The per protocol analysis basically does not tolerate any deviations from protocol, meaning that if there was a crossover, that patient gets eliminated. So that patient is not included in the analysis at all. Okay, so that is what per protocol means. So as you see the name, you will understand that intention to treat, meaning that you have not yet started the treatment. There is an intention to treat. Okay, that is basically at the allocation level, and then you're sticking to that grouping. As treated, when they got treated and any protocol violation happened or they got switched or whatever happened, you are taking the patients as they were treated and you are maintaining them in those groups. Per protocol, it's very strict about protocol. If there is any protocol violation crossovers, those patients get eliminated from the analysis. I hope this is clear. We shall continue.
So the trial procedure they have done was, if the patient comes to the emergency, if the patient needs intubation, they will do the intubation. If the patient needs an EVD, they will place an external ventricular drain. The clipping or coiling is a primary treatment. They will undergo within 48 hours. After within 48 hours, immediately within 3 days, that is within 72 hours, from the subarachnoid hemorrhage days to the within 72 hours, interventional lumbar drain is placed. After the aneurysm treatment, only after the primary treatment, they will take a CT scan. The CT scan, they shows there is no cerebral edema and there is no complications or not there. Then they will place a lumbar drain. The lumbar drain, they used to drain 5 ml per hour for 8 days, at least 5 ml per hour for at least 4 days. They should be drained, at least 480 ml in 4 to 8 days duration they should have drained. If they needed in the lumbar drain group, if they needed external ventricular drain, they can be placed according to the local protocol. ICP is monitored according to the local protocol. There is one good safety measures they are taken when there is a ICP is more than 20 millimeter of mercury, or there is a difference of pressure between the EVD or ICP to the lumbar drain. When there is a more than 5 millimeter mercury difference is that they will not drain the lumbar drain. Every day they used to check in transcranial Doppler, CT scan if the clinically suspected vasospasm, or routinely on 7th to 10th day they'll do the CT scan will be done. Mainly CT cerebral angio or MR angio was done, or cerebral digital subtract angiograph was done. Mainly the inclusion criteria includes age 18 years or older, acute subarachnoid hemorrhage diagnosed in CT scan. This is main confirmed by the CT cerebral angio digital subtract angiogram. There is aneurysm was there. The exclusion criteria includes the contraindication for lumbar drain. Absence, there is a cerebral edema, there is a compression of basal cistern and CT scan. The patient is on therapeutic anticoagulant. Patient is pregnant or the patient is undergoing another intervention. There is a life expectancy is going to be minimal, or hemorrhage of other than aneurysm origin they were not taken. No hemorrhage and CT cerebral angio, cerebral brain, CT brain was not taken. Mainly randomization done. 2-arm randomization was done. There is 1:1 randomization was done. One in the lumbar group randomization was done. One is the standard of care treatment was given. The lumbar group, there is a standard of treatment along with the lumbar drain is placed. Mainly randomization is performed by the internet randomization. The method used to be permuted block with the undisclosed block size of 6, and the compensation were evenly rejected. Here there is a stratified randomization was not used. Age, sex, there is a stratified randomization was not done.
Okay, Kumar, I'll pause you for a bit now. Okay. So I wanted to tell a bit about the types of randomizations which are available. Okay. So I hope my screen is visible. Now, there are two specific terms that you will come across whenever you hear the word random in terms of study design. Okay. One is called random sampling and one is called random allocation. Okay, they are two very different things. Random sampling means that the cases that you are taking are being taken randomly from the population. It is at the sampling level that the randomness is there. Random allocation means that those randomly sampled cases, on them what treatment you are giving, that allocation is the random allocation. Okay, so randomization technically means random allocation. Okay, so I'll not talk about random sampling methods. We'll talk about these random sampling methods are far more important in epidemiological studies. For our type of studies in which we usually take the patients who are coming to the hospital and we mostly do a convenience type of sampling, like as and when the patients come, we take them. So because of that, we don't have to bother too much about random sampling methods. But when you're talking about population study, like you're doing a study within the population, huge population outside hospital, then random sampling becomes very important. Okay. Now coming to randomization, there are three types of randomization that I want to talk about. There are many different types. If you look at Wikipedia and all, you will see many different types of randomization schedules are available. But there are three main that I want to focus on. One is called simple randomization, meaning that you do a coin toss. Okay. So basically, if it is heads, the patient goes to this group, and if it is tail, the patient goes to this group. With this, the problem happens is that you end up with unequal groups, meaning that you can get heads more than tails or tails more than heads, and unequal groups will be there. Although technically that is not a major problem, and probability wise, you will eventually end up with almost similar numbers, but still this will lead to unequal groups. Another very simple method of randomization, which actually leads to equal groups, is the envelope method, in which you make chits beforehand and you keep them sealed in an envelope. And as and when the next case comes, you open the envelope and see whether the patient belongs to this group or that group. That way you can ensure that you are having equal groups. So simple randomization can also lead to equal groups. Next comes the method of block randomization. This is a bit confusing, so I want you people to pay attention right now. Okay. So in block randomization, there are three main variables that you need to look at. One is the total sample size that you need, the number of groups that are there, and the block size. Okay. So from the block size, you will be getting the number of blocks that you will be getting. Okay. So let's have an example. No, not let's have an example. Let's just look at it first. Okay. So basically the sample size, the important thing is that the sample size has to be a multiple of the block size. Meaning that if you are looking at a block size of 3, okay, block means a series of allocations. So the allocation, like suppose you have got two groups, A and B. Okay. If you have a block size of 2, then you can either have AB or BA as the sequence of allocation. Okay. Of have AAB, ABA, BBA, BAB, so on and so forth. You basically develop a permutation and combination of the groups within each block. So how it works is that you randomly make such blocks, okay, and then you keep them in a sequence so that the next block is, the person does not know what the next block will be. The person who is allocating will not know what the next block will be. Suppose in the first block it came as AAB, then the next one it can be BAA or BBA or even BBB. Okay, so that is how you create blocks. Okay, and this now it becomes a little self-evident that the sample size has to be a multiple of the block size. Otherwise, you will not end up with a solid number of blocks, a integer number of blocks. Otherwise, you will end up with a decimal number or something like that. Okay, so the number of blocks that you'll be getting will be sample size divided by the block size. So block size you will have to develop beforehand, like decide beforehand. Okay, the number of groups anyway you will know. The sample size anyway you will know. So from that you will be getting a number of blocks. The number of permutations within each block can be computed using this formula, that is b factorial divided by g factorial into b minus g factorial. That is, suppose you had a block size of 4. Okay, like block size of 4. You decided that block size will be 4. In each block you will have 4 different types of allocations. Okay. So 4 factorial means 4 into 3 into 2 into 1. Okay, so that becomes total of 4 into 3 is 12, 2 is 24. Okay, so 4 factorial becomes 24. Divided by the group size, that is your number of groups. Okay, so that is 2 factorial, 2 into 1, 2. And in brackets, the block size minus the group size, that is 4 minus 2 ka factorial. So that becomes 2 factorial. In the end, it ends up as 24 by 4, which is basically 6. So you end up with 6 blocks, which are kept like this here. So now this seems a little confusing, but practically speaking, all of this is done automatically by you have many internet programs, or you can have standalone programs which will do this for you. This is not a very big problem. Just you need to understand the concept of block randomization. Okay, I hope this is clear. If anybody is not clear, we can clarify at the end of the video. Okay. Now, the last one is your stratified randomization. So in stratified randomization, what you do is you basically, like suppose you the religion of a person, religion of a case is important for you, maybe because of their diet or whatever. Okay. So in the population, you will have various religions in different percentages. Okay. So your the sample that you are taking, you want it to reflect that important variable, the religion variable, in your sample also. So because of that, what you do, what you will do is you will pre-allocate this much percent samples have to be Hindus. This much percentage has to be Muslims. This much percentage has to be Christians, and so on. Okay. So once you have set all of them, after that, within each of them, you can do a simple randomization or a block randomization depending on your requirements. The important thing is that you are pre-specifying that this 1 or 2 or whatever number of variables are very important for you for your study design, and you want to make sure that they mirror the population exactly. Okay, so that is the benefit of stratified randomization. Now, I hope this is clear, so I'll stop sharing now. Nandakumar, you can continue with your video.
So now coming to the randomization, here there is a 300 patients, 307 patient of randomization was taken. In that, the 155% was in the assignment lumbar drain, and 152 patient was in the standard group. From that, there is an 11 patient have been removed because due to the multiple reasons, because of concern, because of the anticoagulant randomization problems. The total finally they came to the conclusion randomization was 144 patient in the lumbar group and 143 patient in the standard of group. The intention to treat patient, whoever is the 144 patient, whoever in the lumbar drain group, they taken as a lumbar drain group, they were taken the treatment protocol, they have seen the primary and secondary outcome. Even there is a 35 patient from the protocol deviation was there in that group, in the lumbar drain group. There is a 35 patient, there is a protocol deviation was there. Main protocol deviation is because due to the drain is not placed or drain inserted, but they not removed the adequate amount of the CSF was not drained. So if you see here in lumbar drain group, they undergone 109 patients only. They have per protocol analysis. There is a stick to the protocol. They followed only 109 patient. If you see then the standard of intention to treat patient, this 144 patients they taken, even they included 35 patient protocol deviation were being included. That is called intention to treat. That is the intention to treat, because most is a real time scenarios. Most of the time they will not give consent, they will not follow the treatment groups. So intention to treat is very important. So here there is intention to treat is 144 patient in the lumbar group was the intention to treat. If you see in per protocol analysis, the per protocol, strict to the protocol they followed were there is 109 patient in the lumbar drain group. If you see in the standard of care group, there is a 141 patient, they followed the pure protocol. What is the allotted the day one, they followed that one. So if you see in per protocol analysis, they studied 109 patient in the lumbar drain group and 141 patient in the standard of care group. If you see in intention to treat group, they are taken 144 patient in the lumbar drain group, 143 patient in the standard of care group they are taken. Now coming for an as treated analysis, if you see this here, the 35 patient from the protocol deviation was there. They were given the standard of care was given to for that patient. So that patient comes to a standard of care treatment. So if you see as treated per protocol, as treated analysis, if you see from 141 plus 35, 176 patient as treated as a standard of care. Here from the there is standard of care, there is a 2 patient, there is a protocol deviation, they received more than 480 ml of CSF was drained. They comes to the lumbar drain group. There is a 111 patient. This as treated as a lumbar drain was placed. Is a as treated protocol. If you see in intention treat in lumbar drain group 144 patient, the per protocol analysis they tried was 109 patient. As treated analysis was 111 patient. In standard of care group, there is a intention treat was 143 patient. As a per protocol analysis they tried was 141. But as treated analysis was 176 patients they were taken included in the study. Now coming to the statistic analysis. The statistic analysis was not previously the power to calculate how much patient is needed is very difficult, because with the previous study, the Loomis study was going, they're not able to take from that study. But previous multiple studies, they have seen retrospective studies. In that retrospective studies, they have shown there is a significant mortality benefit was there. But it looks like logistically it is not appropriate to take. So they study, the people are taken 300 patients in the study group they are taken. From the 300 patients, there is a reduction in unfavorable outcome 50 to 33%. If it comes, there is a 85% is the real, is the 85% is the power. Here there is an, when there is a dip, when you're taking 300 patients, there is an unfavorable outcome decreases from 50 to 33%. The power ratio is 85%. That is 85% sure the reduction is a real difference is going to exist. Here there is a 5% is alpha error is there. Alpha error is a false positivity will be there. Only the 5% will be there. It is a alpha error.
Okay. Nandakumar, I'll pause you again. Is that okay?
Yes, sir.
Okay. Okay. So, okay. So now we come to the crux basically of statistical analysis. Now the thing is that there are, whenever you talk about like, why do you need analysis? Okay. Because you are not very sure of the results that you are getting from the data that you have collected. Okay. Now imagine that in the population, there is some true effect, okay, that you want to see. Okay, there exists a true effect or a true estimate that you want to see. Okay, you take a sample from the population and you get a little different effect, which is not exactly equal to the true effect, but you do not actually know what the true effect is also. Okay, now this difference between the true effect and your sample effect, okay, this is called an error. Okay, so basically you assume from beforehand that because you do not know shit about the population, you know something about your sample, but you assume beforehand that it is always going to have some sort of error. Okay, now where can this error come from? Okay, error means error in estimating the effect that you want to see. Okay, where can this error come from? The error can come from broadly two places: known reasons and unknown reasons. Okay, if you know the cause of the error, okay, then it is known as a systematic error or a bias. And it can be corrected by improving your measurements, by improving your study design, by improving your sampling, etc., etc., etc. The crux is that if it is a systematic error or a bias, it can be corrected. Okay. Next type of error is where you do not know where it is coming from, where the error is coming from. Okay. That type of error is called a random error. And the only way of improving upon the random error is to increase your sample size so that it sort of goes near to the population. So the nearer your sample size is to the population size, the less will be the random error and the more better will be the results. Now, remember that I told in the beginning, you will never know the true extent of the error, right? Because you have no idea about the true population effect. Okay. All you can do is assume that within the context of my small sample size, this much error is going to be there. Okay, so the estimation of the magnitude of the random error is one of the biggest parts of statistical analysis. Okay, now this estimate of the random error is called standard error. I hope everybody has learned the term. They know it from the beforehand that it is called standard error. Okay, the standard error, I'll repeat again, is the estimate of random error vis-a-vis the sample that you have. Now, again, it is all an estimate. Like you will never know the true extent of it. It is all based on multiple assumptions. Okay. So let's continue. Okay, before we continue on this, I'll just give a brief idea about blinding. So this study that we were studying right now is an open label study in which there is no blinding. That basically means that the intervention cannot be blinded either from the patient or from the data collector or from the analyst. It cannot be done. Okay. The single blinding means that the intervention is blinded to the patient. Double blinding means that the patient as well as the data collector does not know. And triple blinding means that the patient, the data collector, or the data analyst do not know the intervention on that patient. Okay. Now, let's go on to some other types of errors. We just talked about standard error. Okay. Now, for now, just keep that idea aside and let's look at these specific things that plague our understanding of statistical analysis. Okay. Now, the way I'd like to teach this is assume that there is a true reality. Like we said, there is a true population effect. There is a true reality. Okay. And you have got your samples reality. Okay. So all you know is the samples reality and assume that there is a true reality also. Okay. When the true reality says that there is no effect, but your sample reality, you are finding an effect, then it is called an alpha error. Okay. When there is true effect in the population or in the true reality, but in your sample, you're not finding that effect, then it is called a beta error. Okay. the opposite of beta error, meaning that there is an effect and the probability of the ability to find that effect is called power. So that is basically the opposite of beta error. Okay. Last comes p-value. P-value is basically the extent of alpha error that you are ready to tolerate. Okay. Most of the time, you will not know shit about your alpha error. Okay. You just assume that I want this much alpha error and not more than that. You pre-specify that only 5% deviation from true effect is supposed to happen. Okay. So the p-value is basically adherence to the alpha error. If your p-value comes more than 0.05 or whatever you have pre-specified as your alpha error, then you say that the effect is not true. And if it is less than 0.05, you say that the effect is true. Okay, I'm not going to talk about alternate hypothesis, null hypothesis. Just think of it from the point of view, there is a true reality, there is a sample reality. True reality, yes. Your sample, no. That's a beta error. True reality, no. Your sample reality, yes. That is an alpha error. Opposite of the beta error is power, and the p-value is the alpha error that you are ready to tolerate. Okay. I hope this was clear because this can go on for a pretty long time. I will pause it now. If any questions are there, we'll field it at the end of the session. Anand Kumar, you can continue.
So we seen the reason they taken a 300 patients was taken to decrease the unfavorable outcome. They decrease unfavorable outcome from the 50 to 33% with the power of 85. That is 85% is a true real, it's going to be exist, and there is a 5% alpha error will be there, the false positivity will be there.
Okay, Anand Kumar, can you pause for a bit? In this slide, I want to show something. Pause means you can mute yourself. Don't remove. Like I want to see the slide, but you just mute yourself. Yeah. Can you hear me? I think someone, can you hear me? Okay.
Yes, sir, we can hear you.
Okay. Can you go back to the slide? Okay. So in this, like the way this is written out in this can be a little bit confusing for people to understand. So I will clarify it. So how they decided on the sample size was that they saw from previous studies that the rate of unfavorable outcome in these type of patients is usually around 50%. They saw it from previous studies. Okay. What they want to do is by instituting the early drain, they want to reduce this percentage of unfavorable outcome to 33%. So it is a difference of proportions. This is the effect that they are trying to see. Remember, I keep talking about effect. The effect here is that you want to reduce the rate of unfavorable outcome from 50% to 33%. So it's basically like a 17% drop. Okay. Now to see this 17% drop, they want to have a power of 85%. This 85% is a little weird choice because usually people stick to 80% or 95% or 99%, but these people have stuck to 85%. So let's talk about that. So what they want is that if you repeated this same study in the exact same format multiple times, like infinite number of times, 85% of the time you will be seeing this reduction from 50% to 33%. Okay. And for exactly this effect, they calculated that the sample size required is 300. You can, if you go beyond 300, then definitely your power will be higher. If you go lower than 300, most likely your achieved power will be somewhere around whatever. Like if you go down the sample size, then basically your power will keep reducing. Okay. I hope this makes it a little clearer. Now we'll continue.
So mainly they used software version was R software 4.10 version they used. Here missing data were not imputed. The category data were used, yes or no questions were answered by C-square test. The continuous variables like age, systolic blood pressures, and MAP was analyzed using the median and interquartile range with a man-Whiteley view test. Repeated measurements, daily data tracing was analyzed using the mixed model and adjusted for uneven data. Here the logistic regression risk ratio was used for analyzing the effect of the treatment. Here the odds ratio was converted into risk ratio because odds ratio is it is a less intuitive. So they used the ratio because risk ratio is easily understood in general public. So used a risk ratio, making the result easier to understand. They adjusted for other factors like if the patient have admitted with intracranial hemorrhage and there is no stratified randomization was not done. There was a mild, there is an inequality was there with Hunt and Hess classification and the presence of intracranial hemorrhage or intraventricular hemorrhage. So that were adjusted according to the needed. They were also tried to different combination factors to check for the pattern. The statistic model, there is exactly the best fit model for an Akin information criterion was used. So intervention group, we already seen the randomization. There was 144 patients was there in the in lumbar drain group. Then standard group 143 patients were drained. 143 patients were then. Drain was started within 72 hours of the post hemorrhage, that is post SCH. Mainly they seen the primary outcome was the modified Rankin scale at 6 months. So always we know that there is a favorable outcome in 0 to 2. I already told 0 to 2 months they will be there without any dependency. Unfavorable outcome is 3 to 6. That is they will be dependent with the dependency. They mainly they seen the secondary outcome also. Secondary infarction, the vasospasm incident, infarction, Barthel score, and Glasgow outcome extended score, mortality, and also requirement of ventricular peritoneal shunt. The results interpretations they were made. The results and interpretations were there. Now coming to this one. So if you see there is a primary endpoint, they are seen the modified Rankin score. There is a 3 to 6. There is an unfavorable outcome 6 months when they seen. If you see in the lumbar drain group, there is only 32.6%. There is a lumbar drain group were there. If you see in a standard of care group, there is a 44.8%. There is an unfavorable outcome was there. So it is very statistically significant. And there is a relative risk also was there is a 0.73. That is means 25%, 27%. There is a reduction in there is a poorer outcome in lumbar drain group compared to the standard of care. There is a relative risk is 0.73. If you coming to the secondary outcome, infarction at discharge, there was a 28.5% in lumbar group, and in the standard of care group there is a around 40% was there. This is also very statistically significant. There is a less than 0.05 this one. If you see here relative risk also, there is a 0.71. That is a 29%. There have reduction in infarction at the discharge in lumbar drain group compared to the standard of care group. Same thing, it was extrapolated. They not only seen the modified Rankin score, they also seen the Glasgow outcome score, extended Glasgow outcome score. If you see in Glasgow outcome score, 1 to 4 is an unfavorable outcome. Only 5 to 8 is an favorable outcome will be there. So in see in the lumbar drain group, there is an unfavorable outcome is only 26.4%. And in standard of care group, if you see, there is around 40%. This is also very statistically significant. And also there is a relative risk also very significant here. So Barthel score, there is Barthel score always it has to be less number has to be there. When there is a more number has to be there. When less number is there, there will be dependent on others. So next coming to this is the intention to treat protocol. If you seeing for separately when you seeing for per protocol analysis, there is also significant there is a reduction in lumbar drain group compared to the standard of care group. That is also statistically significant. So coming to the US treated protocol, there also there is a lumbar drain group. There is a less favorable outcome was there compared to the standard of care groups. This is also statistically significant. So coming to the
I'll pause you for a bit.
Yes, sir.
Keep this slide. Don't remove it. Just mute yourself. That's it. Okay. Make this full screen. Okay. So in this slide, there are multiple things going on. So I want you to understand there are few concepts here that I want to clarify. First is the concept of relative risk. Okay, so relative risk is is basically the probability of the outcome in one of the groups divided by the probability of outcome in the other group. Okay, so here, what is the probability of outcome? It's basically how many patients deteriorated. Okay, so in the lumbar drain group, it is 47 by 144, that is 32.6%. And in the standard of care group, it is 44.8%. If you divide this 32.6 by 44.8, the number that you will get is the 0.73 that you are seeing as the relative risk there. Okay. Now, the next part of it is the confidence intervals. This is again a concept that many people get confused over. So I'll elaborate on this a little bit, but I want to elaborate this on this a lot more, maybe in some next lecture when we have it. Okay. What the confidence interval means is that if you repeated this same study in the same format from the same population infinite number of times, you will have some variability in this relative risk or whatever other estimate you are trying to achieve. Okay. So this variability will be most of the time, that is 95% of the time, will be between this level and that level. That is here. In this study, you got 0.73, but if you repeated the study infinite number of times, 95% of the times, your relative risk will lie between 0.51 to 0.98. Okay, so that is what the 95% confidence levels mean. Okay, next, this confidence limits is usually derived from the standard error, which is calculated for each estimate that you calculate in your statistical analysis. Okay, now let's go on to the next part, that if this confidence level here, the higher confidence level, the 0.98, if it went beyond 1, okay, that would signal that sometimes your poorer outcome was more in lumbar drain group than in the standard of care group, right? Now, this crossover of a crucial junction, okay, here the crucial junction is 1. So if your 95% confidence levels crossed or straddled that crucial junction, then basically your p-value will never come significant, meaning that you are not assured that 95% of the times this intervention that you are doing will have a good effect. Okay, like it can have a deteriorating effect also. In some cases, a small number of cases, but still it is significant enough that 95% of the times it is not happening favorably for you. Okay, so many times your p-value is not that important. This confidence level is far more important, because this confidence level actually tells you the extent to which your estimate can vary and your conclusions can vary. Okay. Next, coming to here, they have specified that they did a logistic regression. Okay. When you do a logistic regression, the effect that you get is an odds ratio. So I wanted to clarify what is the difference between an odds ratio and relative risk. Many times when we colloquially talk about probability and odds and stuff like this, we tend to conflate all of them, that probability and odds are almost the same thing. Okay. They may almost be the same thing, but they are not exactly the same thing. Okay. Odds is probability of event divided by 1 minus probability of event divided by probability of event in the other group divided by 1 minus probability of the event in other group. So odds technically is probability of the event happening divided by probability of the event not happening. That is what the odds is. Okay. So here though, for relative risk, it is probability of the event happening in one group divided by probability of the event happening in the other group. Okay. So technically, if your relative risk is increasing or decreasing, the odds ratio will also follow it, increase or decrease. But they mean fundamentally different things. Okay. That is one thing what I wanted to clarify. Next is that here in this table, you will see a lot of the table is given to intention to treat analysis. The top part is intention to treat analysis. And below they have done something called a sensitivity analysis by repeating the primary outcome and some of the secondary outcomes as per protocol and as treated analysis. So they wanted to do this to see whether in the real world where crossovers do happen, does that influence the outcome? That if crossovers do happen, then does lumbar drain still retain its efficacy or not? Okay, so to test that, this question basically, they did the per protocol and as treated analysis. Fortunately, everything came in the same line. Basically, it leads to an improvement in favorable outcomes or decrease in unfavorable outcomes, whether you do it as intention to treat, as per protocol, or as treated. So this confirms and increases the robustness of your findings that in a real world scenario, if you instituted early lumbar drain and like you instituted, later on it got blocked, or you did not institute it early, later on you instituted after some time, and still you will lead to a more favorable outcome. Okay, so that is called the sensitivity analysis of it. There are more technicalities to it in which you can actually compare the relative risk also or odds ratio if it is presented. You can do comparisons of those also and find p-values for those also. Then there are types of analysis in which the crossover itself is taken as a separate variable and used for logistic regression as a confounding factor for this analysis. So there are many different ways in which this can be done, but the fundamental meaning of doing this sensitivity analysis is what I told you. Now, Nankumar, let's continue.
So now coming to, because this robustness of the study was because both intention to treat or sensitive on is per protocol or as treated, everywhere they are seeing the confidence interval was studied in every group, even the secondary outcome group. Everywhere they were seeing the relative risk as a confidence interval was checked. Next, coming to the absolute difference, absolute risk difference were there is a minus 0.12%, 0.12 was there. Negative comes, the reduction is, there is a 12%, there is a reduction in the lumbar drain group, the outcome is, reduction is there. Both, even the secondary infarction rate is decreased, there is 11% decrease in secondary infarction in the lumbar drain group.
Then Nankumar, this will actually continue in the same way, so let's just go on to the next slide.
Now coming to this, they have done a subgroup analysis by using a forest block. So if you see in the group, he told there is a one is a confident interval. When you see there is a one is there is a right side is a lumbar drain group. So right side, left side is a lumbar drain group. Right side is a standard of care group. The most of the time, mostly it stays nearing towards the 0.75. The relative risk in the modified Rankin scale is 0.75. If you see, particularly if you see, there is a, when there is a modified, there is a Fisher grading was there. There is a 4 Fisher grading was there. When there is a modified Fisher radiological grading, there is a 4 was there. Means there is a thick SAH with interventricular extension. There is a significant, there is an improvement in relative risk was there. There is a, when they see the confidence interval, small confidence interval, and also they are not touching towards the 1. There is a less than 1 towards there. It is a very significant. Next, coming to the, if the patient is presented with intracerebral hemorrhage, that also there is a relative risk, there is a confidence interval is less. So with the interventricular, even there is interventricular extension is there, that is also a little bit significant, not specifically more significant like there is a modified Fisher grading 4. So this was this study mostly it was recruited from the 2 centers. So in the 2 centers only they have shown the outcome was there. Then other recruited center they are not shown much benefit was not there. So this is the flaw of this study. Next,
can you go back? I'll show a bit how the forest plot has to be interpreted. So, yeah, you can make it. Okay. So, you remember the last time like in the last section, I told you that there is always that crucial junction or the boundary point that your confidence level should not straddle, right? So here they have put that line at 1. You can see this faint line, vertical line at 1. This is basically that crucial junction that your confidence level should not straddle. Like if your confidence level straddles this, then your effect is not going to be significant. So here you can see that there are a lot of, so in this, the squares in the middle, all of them are the actual estimates that you have gotten from your analysis. These are basically the relative risks. The side whiskers that you see, those whiskers are the confidence levels, the 95% confidence levels. Okay. For all of these analysis, these subgroup analysis, you can see that this whisker is touching or it is straddling the line, the crucial junction that you should not straddle. Okay. So because of that, you are seeing that the p-value, all of them are not significant. Okay. So I hope this part is clear. In this, there is another term called interactions. I will not specifically go into it. That we'll do some other time when we have time. Okay. Now, Nandakumar, continue.
So if you see only in the two center, the study have shown a little bit significant was that if another recruited center, they are not shown. It crosses the confidence one was there. So, every section there is a p-value is not significant. This is the intention to treat. We discussed. There is a large number of people was there in the modified Ransom score of 0 to 2. The less people, less unfavorable outcome was less in the lumbar drain group. This the mortality was specific. The mortality was done by the Cox proportional hazard analysis. There is no mortality significant was not significant. Coming to the strength of the study, it was a randomized study. There is a 1:1 randomization was done with internet randomization was done, but there is a no there is a specific standardized stratification was not performed. There is an endpoint assessment was blinded. This intention treat analysis was done. The multiple sensitivity analysis per protocol as treated reinforced the robustness of the study. The weakness of the study is it's not a randomized, it is a not stratified randomization with the age or any groups were not specified, but subgroup there is a randomization was done, but straightforward there is a no standardization was not done. There is an open label study. Both the patient and the patient and the physician were aware of the treatment, but in this study, the most of the physician will be aware of the treatment because it is if the patient is going to have lumbar drain, they used to know what is the treatment is going on. There is a selection, there is an external validity. It is even the multi-centered trial. There is most of the studies taken from the 2 centers. So it is limits the generalizability. There is a minimal the crossover was there. If you see in lumbar drain group, there is a protocol deviation was there for 35 patients. That is a 25% of the patient, 25% of the people in the lumbar group have protocol deviation was there. That was criticized. The lack of standardized the vasospasm, when the patient gets in vasospasm, there is no clear-cut the treatment guidelines were not there. So mainly there is the studied, we already discussed primary outcome, they studied about the modified Ransom criteria. Secondary outcome, there mainly the secondary infarction, both shows the significant improvement in outcome was there. There is a mortality, there is no significant mortality benefit was not there. If you see an adverse effect, one patient have increase in the pressure, though the lumbar drain was not continued. One patient have skin infection, surgical debridement was undergone. One patient have lumbar drain dislodgement, so they are removed through the surgical result. They're not even one case of reported as a meningitis was not there. Only they were reported as a pneumonia case was there. So clinical implication recommendation, the study provided strong evidence that lumbar drainage can improve the functional outcome in aneurysm subarachnoid patient. The practical changes is given the significant reduction unfavorable outcome in secondary infarction, lumbar drain would be considered in early management of aneurysm subarachnoid hemorrhage, particularly in patients without contraindication. There is a number need to treat. If you see the unfavorable outcome reduction, there is a 1 in 8 patients. If you treat, there is a decrease in unfavorable outcome was there. It is quite significant. So further research should be involved in the optimize optimal drainage volume, timing, and the patient selections criteria. So compelling the evidence support the conclusion, coming to the conclusion, evidence supporting that use of lumbar drainage in subarachnoid hemorrhage decreases the there is a unfavorable outcome. There is a modified Ramsden's criteria 3 to 6, and there is secondary infarction reduction is there at 6 months. Further research is needed to refine the patient selection criteria and drainage protocols. Coming to our
Nandakumar, we'll skip this critical appraisal part because we have already exceeded the time limit. We'll take the questions now if anybody has questions. Is that okay?
Okay.
If
Okay.
anybody has question, yeah. If anybody has questions, you can speak out, or I can't see the chat, but anybody can speak or put it in the chat. Anybody has any questions? Questions can be as simple, dumb, whatever you consider it. It doesn't matter. If you have any questions that you need clarification, please speak it out or type it out so that I can clarify them. Nobody has any questions? Okay, then we'll let Nandakumar complete his critical presentation.
So, critical appraisals is the basic study designed valid for randomized control trial. Yes, it is a valid because there is a picket. They followed the picket. The population they used was an aneurysm subarachnoid hemorrhage. The intervention they undergone was a early lumbar drain placement and the controlled with a standard of care treatment. The outcome, this unfavorable outcome, the measured at the duration was 6 months. The 6 months duration, the outcome was measured. Is the assignment of the participant to intervention randomized? Yes, they both were randomized equally. With using the internet-based perimeter block randomization was done. Was the randomization sufficient to eliminate the systemic bias? Yes. Was the allocation sequence conceived from the investigator and participant? Yes. For the participant who entered the study, accounted for its conclusion? Yes. So the study group was not stopped in between. Everywhere is continued throughout the study groups. There was no withdrawal was not there. Only there is a deviation was there. There was a 35 patients were excluded from the intervention treatment group. Was the methodology sounds? Was the participant blinded to the intervention they were given? No, they were not blinded. The patient was aware of what the treatment is going on. Whether the investigator blinded to the intervention they were given to the participant? No, it's very difficult to blind for the physician because he will be aware inside the ICU, inside the hospital, he will be aware of what is the treatment is going on. It is difficult to go give a blinding. This physician is blinding is very difficult. The people assessing the analyzer outcome was blinded. Yes, the outcome assessor was unaware of the treatment, and also radiologist who were seeing the infarction also was unaware of the what was the treatment group they undergone. This is both the side, radiologist side and also the outcome assessor side was blinded. Was the study group similar at the start of the randomization control trial? Yes, the both group have the same group of people was there. If you see in lumbar drain group, they have more Hunt and Hess classification 1 and 2. In standard of group, they have few intercranial hemorrhages were there. They were statistically adjusted according to the imbalance. Where the baseline characters of each study groups clearly set out. Initially, it was not set out, it was not certified, but later in subgroup analysis, they made out, clearly they made out. Where there is any difference between the study groups, they would affect the outcome? No. Apart from the experiment interventions, did each study group receive the same level of care? Yes, both the group received the all standard of care. Only in study protocol group, they received the lumbar drain was there. Was the result comprehensive? Yes, the primary, if you see the power calculation was adequate, that 85% power was there, alpha error is only 0.5%. The primary outcome they measured was there is a decreased unfavorable outcome. There is a modified Rankin's criteria, and also there is a secondary infarction rate is less in the lumbar drain group. They mainly they used the relative risk was used. Here there is a no missing data was not imputed. There is a no dropout of the patients were not there. There is a.
Kumar, I'll pause you for a bit.
Yes, sir.
So in this, there's one question that I think you have wrongly answered. So in this, the question is, was a power calculation undertaken? Okay. So the power calculation undertaking is, when they speak about it in the context of the results of a study, is called a post hoc power calculation, meaning that from whatever results you got from your own study, okay, from that you are extrapolating that how much power did I manage to achieve. Okay, this 85% is the power that they hope to achieve with the sample size of 300. Okay, now you have collected the 300 samples, you have done your study, you have tabulated your results. Now you want to see whether you managed to get what was the exact power that you got from your study. Okay, so there are methods of calculating power for every estimate. So in this, they have not actually done a post hoc power analysis, but since the p-value is less than 0.05 for the samples that for the important outcomes, you can be assured that they have achieved the power that they were planning to achieve. Okay. So this, they have not conducted a post hoc power calculation. That's something I wanted to point out. Sure. Continue. Ram Kumar, am I audible?
Yes, sir, you are audible.
Okay. Nand Kumar, you can continue. Nand Kumar, you are still muted.
Sorry. There is a precision of the estimate. They are saying there is a decrease in absolute risk reduction was there in the unfavorable outcome, and also secondary infarction. The infarction rate also have been decreased in the lumbar drain group. If you see the harm, there is a less harm was there. There is a not much infection was not reported. The only one case, the local site infection was there. There is a drain displacement was there. There is surgically removed. There is no major complication was not reported. Was the effectiveness analysis undertaken? So very difficult. Cost effectiveness was not undertaken in this study because the lumbar drain is not much cost effective. It was not taken, I think. Was the result helpful in your locally? Can the result is applied to your local population in your context? Yes, with some consideration has to be done. If it's in Indian population, there is we're doing the lumbar drain in every hospital, the chance of infection is going to be more. Not only the infection related, the secondary complication is going to be more. We should be very careful. Only in the tertiary care center, they have good infection control practice. They should be doing this practice. Are the study practice similar to the people in your care? Very difficult to comment this one, because in a Western country, if you see ischemic stroke is 85%, only there is an hemorrhagic stroke is 15%. If you see in Indian population, the 50% is ischemic stroke, 50% of there is an hemorrhagic strokes are there. There is there is uncontrolled blood pressure will be there. The ICH presentation with ICH, the grade of ICH, Fisher's grading will be more in our community. Other risk factors like blood pressure was not measured, previous blood pressures and smoking history, alcohol history was not clearly mentioned in the study group. This will be in our community will be very major problems will be there. Would any difference between your population and study comparison alter the outcome? Because mostly in our population, they will not present immediately to our hospital. They will be presenting in the later stage. Because in that population, within SAH, within 2 to 3 days, they have put on lumbar drain itself after the procedure. In our community, I don't think so it will be much possible, because they will be presenting to the local hospital, from there to other tertiary care, from other tertiary care to our hospital. It takes time. Are the outcome important to our population? Yes, very important, because there is mostly it will be dependent. Is the disability is more significant in our population. If you do properly, there is an outcome will be very important for our population also. Are there any outcome you would have wanted information on what have not been studied or reported? The cost effectiveness was not reported, because they are not done in low income countries. The not study was not come in the low income countries. There is a beyond 6 months of long-term maternal morbidity was not studied. The rate of infection, because they had studied only the two populations, the other low income countries, their infection rates, we don't know how much it's going to be. Are there any limitations of the study that would affect your decision? Very difficult to tell. If the experimental intervention provides greater value to the people in your care than any other existing intervention, no. For the source are needed to introduce, not much source is nodded for. Only there is infection control plays a major role, I think. There is no way to invest for a lumbar drain. There is not much. So we can try to use a lumbar drain. If the infection control practice is good, we can try. There is outcomes how is going to be. The appraisal summary, if you see, it is a well-designed multi-centered RCT. The blinded outcome assessment to reduce the bias. The clear statistical analysis and reportings were done. Clinically relevant findings was there. Negativity, if you see, there is a lack of blinding in the participant and acute caregiver. Stratified randomization is not done. Some people didn't receive their allocation intervention. There is a crossover was there. The unknown is the cost effectiveness of lumbar drain was not assessed. Applicable row resource setting remains uncertain.
Nandakumar, can you go to the section C of the appraisal? This one. Can you mute yourself? Okay. So in this, this is the last, I'll give a brief idea about regressions and then I'll let you go. So eventually, when you are trying to do any sort of statistical analysis, hypothesis testing, like I said, you are trying to look for the association between a cause and an effect. Okay. The most direct way of seeing the association between a cause and an effect is by doing something called regression. Okay. Now, this regression, what it gives you is that with some change in the cause, how much change happens in the effect. Okay, that is effectively the output of any regression. Okay, now the change in the effect by the change in the cause, this change in the effect can be expressed in very different ways depending on what is the type of the outcome variable or the effect variable. Okay, if the outcome variable is something which is like a continuous number, okay, then basically unit increase in the predictive variable will lead to how much average change in the continuous outcome variable. That is done using linear regression. Okay. If the outcome variable is a binary variable, that is yes or a no, like in this case, you have got unfavorable outcome, yes or no. Okay. You want to see whether the predictive variable, that is your lumbar drain, is leading to any change in the proportion of your outcomes. Okay, so in this, the effect will be shown in form of a change in proportions or expressed in form of a relative risk or expressed in form of a odds ratio. So it can be expressed in multiple ways. They will mean almost the same thing. Okay. Now the thing is that the regressions are not just useful for like comparing the cause to the effect, because a single cause with a single effect can also be analyzed in many different ways. Like here, there is a binary variable as the cause and binary variable as the effect. We can very easily do a chi-square analysis to see whether there is any association between these two or not. Okay. You can find the odds ratio also after you do a contingency table of these two, and you can calculate the odds ratio by AD by BC that all of us know, right? Now, the main benefit of regression is that you can add other variables into this association, meaning that suppose some variable here, like they said, the age, the Hunt and the Hess grade, the hemorrhage severity, all of these can influence the connection between your lumbar drain to the unfavorable outcome. Right. So like all of these can actually affect this association. Like if some patient has a higher hemorrhage severity, then the early lumbar drain may not be as effective. Or if it is a higher age patient, then the early lumbar drain may not be as effective. Right. So you want to account for all of these confounding factors. Now, in the study design, you try to do a proper random allocation so that all of these confounding factors are sort of evenly distributed between early lumbar drain and the conventional group, right? But if they are still somehow end up to be different, or you feel that it is clinically relevant for you to account for the effect of all of these, then what you will do is you'll throw all of these factors into the predictive part of the regression to predict the outcome. Okay. What this will do is it will remove the effect of age from the association between early lumbar drain and the outcome. It will remove the effect of Hunt and Hess grade from this. So basically, if you put all of them into the equation, what you eventually get is the true association between your early lumbar drain and the outcome, while accounting for age, Hunt and Hess grade, hemorrhage severity, etc., etc. So whenever you hear the term adjusting for some variable or adjusting for a covariate or anything like that, that basically means that you are throwing all of them into like you're throwing all of these extra variables into your regression equation to account for all of these effects to see the true association between your main positive factor and the main outcome. Okay. So here so the type of regression will depend on what the outcome variable is. Like I said, if it is a continuous outcome variable, you will be using a linear regression. If it is a binary outcome, you will be using a logistic regression. If it is an ordinal variable, you will be using ordinal regression. If it is a multi-nominal variable, okay, which is basically a nominal variable with no order between the levels. Multi-nominal variable, you'll be using a multinomial regression, and so on and so forth. There are many different types of regressions which are there too, but these are the main broad 4 types of regressions that you need to know. Okay, and all of these, the main 2 that you need to know are linear and binary logistic regression. Okay, so I think this is enough. If anybody has any questions, we can field them right now. If not, then we will go about our ways.
Just a quick question. So
Yes.
based on what you have presented, would you be comfortable using lumbar drains? Do you think they work?
Yes, based on the results of this study, definitely they do work. Nankumar, can you unmute yourself? Yeah. So based on the results of this study, definitely they work. And practically it is not a intervention that has much danger to the patient anyway. It will be useful for reducing the ICP anyway. It doesn't have that much risk of meningitis. So I feel that it is worthwhile to try it out in a few patients. Like eventually we will not be basing decisions based on some study. We will be basing decisions on whether it is useful for our patients or not. And we'll be basing that by trying out in a few patients, right? So this study at least tells us that it is safe to use and somewhat effective. So why not try it in a few patients and make up your own mind?
Dr. Dhiman, a couple of things that I wanted to mention before we close off. Dr. Nandakumar, you were mentioning primary outcome and secondary outcome.
Yes, sir.
Can you mute yourself? Yeah. So this study was set out to measure the primary outcome difference. That's all. And the primary outcome was the Glasgow outcome scale. That's it. The secondary outcomes do not matter. The number of patients having, ischemic stroke, etc., are irrelevant. Whenever you look at any study, it is it's the primary outcome that matters, because they are powered only to measure the primary outcome difference. That's point number one that I wanted to mention. The second point that I want to mention, especially for this study, is I think most of them have gone, but still some are left. You, in your very first slide, you mentioned that it is the degraded blood that causes vasospasm. So you and I will think that if there is more blood, there is more risk of vasospasm. So I would prefer to try this on patients who have more blood, where the risk of vasospasm is more. So by doing the lumbar drain, I will see if my risk comes down. But if you look at the trial, they have excluded high-grade subarachnoid hemorrhage patients. They've included low-grade subarachnoid hemorrhage patients where the vasospasm risk is low. You're doing a trial in patients who have low risk of vasospasm, not in group of patients with high risk of vasospasm. So you may not may or may not find a big difference by doing an intervention. So that is one point I wanted to mention. The other thing is they have excluded a lot of other patients, about 120, 130 patients without any reason. So whenever you find a trial where a lot of patients were excluded without any reason, you always question the integrity of the trial or internal validity of the trial. So in my mind, I will just wait for more trial results before I start trying this intervention on a regular basis. I might give it a try, but to change my practice, which means within 72 hours, I will put all my high-grade subarachs, I will put lumbar drain in all my high-grade subarachs. I would probably want to have more data before I change my practice completely, and that is my take on that. And I want to take one point home. Whenever you look at any trial, it is the primary outcome that matters. The secondary outcomes do not matter. The subgroup analysis or hypothesis generators, they don't matter.
So in this, like on the clinical point, I will say one thing, that many times it is actually dangerous to put a lumbar drain in patients who have a high grade, because the high grade SH means that they may have a high ICP also. So that sudden reduction in the infratentorial pressures might lead to coning, and also that is why I think that is another exclusion criteria also. That if the basal cisterns are compressed, that basically means high ICP, will be excluding them from putting a early lumbar drain. Right.
Yes, sir. They've mentioned these two things separately. So high ICP was an exclusion criteria, and also for no reason they excluded high grade SHs, and no reason mentioned 120 patients.
Yeah. I understand. So yeah. And on the point of that primary outcome and secondary outcome, definitely whenever you are taking home any lesson from the study, it is the primary outcome, because that's what it is powered for. However, looking at the secondary outcomes actually gives you more ideas for further studies. That is also there. So don't ignore them, but use them appropriately for other reasons. Okay.
Thank you, Dr. Dithiman. Thank you, Dr. Nandakumar, for that presentation.
Thank you.
Thank you, Dr.
Thanks very much. Bye. Good night.
Thanks, Nandakumar. Good night.
Thank you, sir. Thank you.